Hello, I'm Steve Schuster from the University of Pennsylvania in Philadelphia, and I'm here in Miami with my friends and colleagues, Ian Flinn from Sarah Cannon Institute, and Caron Jacobson from Dana-Farber in Boston, Fred Locke from Moffitt in Florida, and we're all here at the first international workshop for CAR T-cell therapy. This is a kind of an exciting meeting for us to be able to get together and share our unique experiences, personal experiences with the different CAR T-cell products, the directions we're moving in, sharing our perception of the impact that this technology is going to have on our fields. All of us treat lymphoid malignancies, primarily lymphomas. So I'm interested in hearing their impression of this meeting. Ian, what do you think?
Well, I think the data's been really exciting so far. We're getting updates on some of the data that we've already known, but teasing down into subsets of the data sets to get a better granularity of the information.
Yeah, I think now, I mean, the perspective is going from these response rates that initially were reported in months to years of follow-up now. So it's clear that at least in aggressive large B-cell lymphoma, a third of the patients are going to be long-term disease-free survivors. The group of patients that didn't have a good therapeutic options previously. I think that's an achievement. Although I still think there's space. Caron, what do you think?
Yeah, so I think a big challenge of a meeting like this is to identify what the unmet needs are and how we're going to best study them so that we can move things forward. I was really interested to see some of the work that Fred's done, looking at tumor-associated macrophages and some of the myeloid suppressor cells and how that's correlated with response or lack thereof. And we think we need more data like that to identify what the next addition to CAR T-cell.
I can't wait till ASH to hear more of that from. I have this feeling we're going to hear more, Caron.
Yeah, I think so too.
Yeah, I think it's a great meeting, and it is great to share all our own experiences, especially with the different CAR T-cell products for diffuse large B-cell lymphoma. It's critical that we collect samples and we study them and try to figure out why these therapies work or don't work, because 35, 40% durable remissions at 2 years is great. But what about the other 60, 65% of patients? And we just do not understand fully why those therapies aren't working.
Exactly. And I mean, the extent of expansion in peripheral blood of these CAR T cells is the same in patients that respond and don't respond. And we've looked at phenotypes of the cells in the blood, et cetera. And, the answer is not going to be found easily, in that type of sample. I actually think the action in lymphoma, unlike ALL and CLL, where the blood results are much more meaningful because the targets and agents are together. The answer is probably in the tissues and going to require more biopsies, and probably biopsies that are not necessarily even biased by failure or success, but biopsying of all patients so that we can discern differences.
So you said something interesting. So you said that the expansion is the same for all patients, whether they're responding or not responding. I know one thing with Axicabtagene ciloleucel, we showed this in the ZUMA-1 trial, is that the patients who have responses actually do have greater expansion, actually within the first 1 month of therapy. And those with durable responses have even more expansion. Now, I think in our mind, it's why is there a difference in expansion? But maybe
so
the products are different.
That's definitely unique to the CD28 product. We did our own trial of 56 patients and then another 115 on the multi-center Juliet trial with the 4-1BB agent Tisagenlecleucel. And I did my own analysis first, and then independently, a very sophisticated, pharmacologist analyzed the data from the multi-center trial, and and we could see nothing with this. And really, even looking at the initial papers that were published, at least Satva's and your paper from the New England, the first paper, those box plots are not hugely different. I mean, it's not like the cells aren't growing.
Those are log scales, and there's no doubt there's some patients with expansion, but it's pretty clear that the patients with durable responses are those who have the best expansion. And in fact, when we look closer, it's really the expansion in relation to the tumor burden itself. So there's a target to effector ratio, if you will, that needs to be achieved. Now this is with Axicabtagene ciloleucel, a CD28 costimulatory CAR-T for large B-cell lymphoma. It may simply be that with a 4-1BB construct, Tisagenlecleucel, that it's not so much the expansion, maybe it's the persistence, the continuous activity. I don't know.
The kinetics are definitely different. I mean, the peaks are much earlier and brisker with CD28 co-stimulatory domain, and a day or two later and more persistent with the 4-1BB. So actually, some of this may be related to the constructs themselves, but I have no doubt that the quality of the T cells that we use to generate the products, are going to vary between patients that are heavily pretreated or have large tumor volumes, and as well as by the construct, and I think there's a lot of variables.
Getting to some of those points, I think Ian discussed sort of the role of auto transplant in the era of CAR T cells, and you presented the randomized trials. What do you predict in 5 years we're going to be doing for relapse?
That's right, we're doing 3 trials. Yeah. So tell us how they're going to end, Ian.
Well,
we all had predictions, so we can.
I know the answer.
Yeah, I do think we're actually in a state of equipoise. I mean, I do think these trials are 100% ethical. What I think might not actually pan out to be true. What we do know is that the outcomes for people who have relapsed within 12 months of their first-line therapy is dismal, right?
It's terrible.
And so hopefully that using CAR T cells in that setting, so these 3 trials randomizing patients to in first relapse to either receive standard of care, which is salvage followed by transplant if sensitive, versus CAR T cells. I mean, I think they're tremendously important. Now, my bias is right that the CAR T cells are going to be better, but based on the results that we've already discussed, that patients who relapse after auto transplant respond, and you can salvage up to 40% of these people.
I think you're exactly right. I mean, we've identified the bad actors in the rituximab era, the ones that have primary refractory or early progression of disease. Whether it's from after primary therapy or the inability to get a remission, or after an auto transplant progression within a year. We, Scholar 1 retrospective data support that, and it's been pretty much you can almost have predicted that looking at the data you showed today from the Carl trial, et cetera.
It'd be interesting to whether some of these immunological correlates that you talked about, the inflammatory markers and things like that, whether that holds up in that that second line therapy population, or it's just because people are so far progressed.
Yeah, I mean, I believe one of the things we saw in our commercial Axicabtagene patients is that these inflammatory markers predict for decreased opportunity for durable response, whether it be ferritin, CRP, IL-6, TNF. Yeah. These things in the serum predict for lack of durable response. I do have a sense, and we have some data to back this up, that patients with more lines of therapy who've had more progressive disease are more likely to have that pro-inflammatory disease-driven state. So maybe earlier on we will see more durable responses. But what's remarkable to me is that when we look in our real-world data or our standard of care data with Axicabtagene across 17 centers, 300 patients apheresed, 277 given Axicabtagene ciloleucel for large B-cell lymphoma and its variants, we see durable responses, actually overall response rate, CR rate, and durable response rate, at least with 9+ months follow-up, is very similar to ZUMA-1. And these are patients who are even worse off. So that makes me start worse off in terms of risk factors, disease burden.
I think it's very reassuring.
It's reassuring, but it makes
to know
me wonder
that these technologies are applicable in the world outside of Florida,
yeah,
and or Philadelphia or Boston, or Nashville. I think that the real world experience, and you'll see more stuff coming out at this ASH meeting from with the other products as well. It's very reassuring that people are replicating the early studies that were done. Mm-hmm. Is there a patient that you wouldn't treat? Okay, for example, yes, there are patients with large tumor volume, high LDH, have a worse outcome. Are there criteria that we use to decide to treat or not treat a patient?
There are at our center, and really it's a patient with, and I think you mentioned this in the session, a patient with rapidly progressive disease, a patient that has a pro-inflammatory state, rapidly growing disease. It's not that we would never treat that patient eventually, but we want to cool that patient off. We want to
there are, we can all have a bunch of criteria, but there's no hard and fast criteria for that sort of just gestalt that there's someone who's not going to be in good shape 3 weeks later, right? Those are really hard decisions to make when there's a patient in front of you.
And a lot of it, I think, comes with experience. Like I can look at when I first started treating patients in 2013 to my success rate versus my success rate now when I treat patients. The learning curve is tremendous. You can, as Fred just said, if a patient is clearly, losing performance status and growing before your eyes, that patient is not going to do well. And interestingly, they generally do have high inflammatory markers like C-reactive protein. But also interesting, I've never seen a patient respond who has not increased their C-reactive protein after getting the T cell.
So certainly there's a pro-inflammatory state induced by the CAR T cells themselves. We have cytokine release syndrome, and CRP is one of those things we follow along with cytokine release syndrome. I think there's data coming out of ZUMA-1 as well that ongoing inflammatory state may actually impact efficacy expansion as well. So more CRS may be also bad for efficacy.
Exhaustion, maybe.
Yeah.
Sort of like I'm feeling right now, having gotten in late yesterday. But in any event, I think the meeting has been great, and I certainly have learned a lot. One other thing I thought that came out that was particularly interesting to me was the fact that some of the small molecule BTK inhibitors have such tremendous immunomodulatory effects beyond their anti-tumor effects, very quick activity on T cells, and how they actually can ameliorate some of the side effects of specific to CAR T cell therapy like CRS, yet maintain and even enhance efficacy. We have so much work to do and so much more to learn.
Yeah, I think we definitely have to see if that holds up outside of CLL. Because it's who knows how much of that is a direct effect of the disease on the T cell phenotype.
You debulk and.
Have you guys used ibrutinib or other agents for commercial patients where you use it through collection all the way to CAR T? Is that something you've done before?
So we haven't done that, but we did look at our real world experience at patients who got ibrutinib or lenalidomide leading up. Now, of course, leading up to as their last line of therapy before collection. And unfortunately, those patients it was a very small number of patients, but they did worse. But of course, that's a group of patients. We didn't pick ibrutinib because of its immunomodulatory effects. We picked it because we ran out of other things to treat those patients with. So those may have been a reflection of the disease, right?
So we know how fast the immunomodulatory effects reverse after stopping? I mean, so if they stop like a week before, would you expect to still have them there?
I don't think we know. I know that in vivo, in patients, the Ohio State data suggests that to actually see a change in the circulating peripheral blood T cell immunophenotype takes 5 to 6 months. How fast it reverses if you stop therapy.
Yeah, I've seen some other data that says it can even occur within 4 to 6 weeks. The positive effects, but again, after you stop ibrutinib, I'm not sure when it reverses.
So I've had several patients that had activated B cell origin, diffuse large B cell lymphoma, who were responding to ibrutinib as a third, fourth line therapy, and I've collected those patients, treated those patients, and seen good results, but they happen to be patients that were responding to therapy. So as Caron was saying, there's such a selection bias.
And you've stopped ibrutinib and lenalidomide.
Oh yeah, because that wasn't part of the study that they were on. But I was allowed to do whatever I wanted as bridging. So that's how those patients were collected. I would stop it like the day before we put the lines in.
Yeah, I think prospective studies are needed in this space for lymphoma, not just for CLL, but also for lymphoma, and we'll have to see what happens to the T cell function, but also does it really decrease cytokine release syndrome? That was one of the suggestions in the other talks, and I think we have to study that prospectively.
Yeah.
All right. Well, I think that we have another day to go, and I'm sure there's going to be more. discussion, more things to learn. And I guess they'll regroup in 2 years, every 2 years in general?
No, I think they're planning next year already.
Oh, really?
We'll do it again
Oh,
in
this
a year.
technology's doing it.
Yeah.
Okay. Okay, well, we'll see each other again next year, I guess you say, not in South Beach. And thanks to the audience for joining us.